actually this baby was suffering from trisomy 18, which is 3 copies of chromosome 18. Next slide. And similarly here you can see another numerical chromosomal problem, which is again very common. This is a girl with short stature, primary amenorrhea, and you can see here on the neck, this is the scar of a surgery whereby she had a webbing of her neck and that was excised surgically. So this is a patient affected with Turner syndrome. She's a girl who has only one X chromosome. Normally girls will have 2 X chromosomes. Next slide. So besides the numerical problems, you can have structural problems in chromosomes. Like some part of the chromosomes could be missing, some part could be extra. Sometimes some parts could be rearranged amongst themselves. So these are like deletions when some part of chromosome is missing, translocations when something is rearranged. Next slide. So such structural chromosomal problems can sometimes be balanced, means there is no loss or gain of chromosome material, but the chromosomes got mixed up, kind of rearranged amongst themselves. Like here you can see, this is chromosome 2, the pair chromosome of chromosome 2. This is the normal one, the long one. And here this is the other one which seems broken from here, from the below part. So actually this part has gone and got attached over here. This is chromosome 17. So this is the normal one, the small one. And this big one basically is 17, followed by the rest of it is chromosome number 2. And there is a small part of 17 which we can't make out, which is got actually attached here. So this is a translocation. And this usually does not cause any problem to the person who has it, but when this person tries to reproduce, there can be many problems in the baby. And then here we have like this, and this what is shown is that this is a translocation between chromosome 13 and 13, like both the 13 are attached to each other. This is called as a Robertsonian translocation. And here you have this chromosome 5, where some part of the chromosome 5 is missing. So this is a deletion of chromosome 5, and here you have some extra material. These are marker chromosomes. Next slide. So these are some of the structural chromosomal problem where the number may be normal, but some problem is there in the structure of chromosomes. So here let's see an example now, clinical case scenario. So this, what you're seeing here, these circles and squares basically is how we represent a family in the genetic clinic. So whenever any family comes to us for a geneticist, it is very important to know the history of not only the patient, but of his whole family up till 3 generations. And if we start taking the history of such a huge family, you will fill up some 20-30 pages and it will be very difficult to read again. So what you can do is that just represent it using some diagrams. So that is what this is. This is called as a pedigree. So here we represent as male by square, female by circle, and when they are joined by horizontal line means they are married, and then if there is a vertical line means the offspring line, and then after that here what we are seeing are these triangles. These are basically abortions. So this is a couple where this lady has suffered from 4 abortions. So now when this couple comes to us, so next slide. So we will do some tests. So one of the tests which is recommended is to do a karyotype of the husband and the wife. So when we did this karyotype, we found that the wife had a translocation between chromosome 5 and chromosome number 10, what is indicated by the arrows over here. And it is written like this. So once anybody has this translocation, next slide, what will happen is that such person, so the lady will be normal because her DNA is all there. There is nothing missing in her DNA. It has just got shifted from one chromosome to another. So, but this lady can give rise to very abnormal kind of ovum, and that is why she can come up to you, present in the clinic with abortions or with infertility and so many other problems. So that's what is mentioned here. So there are 16 types of ovum this lady can produce, out of which 4 are usually non-viable, so they present as a fertility. 2 types are normal also, so there are possibility. Actually, nature favors the normal, so usually 60% is the chance that the gametes will be normal only. And then there are 10 other which can have various kind of problems, which can present with either infertility, abortions, late pregnancy loss, or even an abnormal baby. Next slide. So these are the problems which can arise, and here in fact in this lady also, when we did karyotype of one of the abortus, we found that the baby had an abnormality. which arose because of the mother's chromosomes. Next slide. So then, when should we do a karyotype? So karyotype should be done in an OBG clinic whenever any couple is coming with recurrent miscarriages, whenever there is unexplained infertility, amenorrhea in a lady, or premature ovarian failure, any bad obstetric history, and even abnormal ultrasound finding. And even in other clinical settings like neurology or pediatrics, if any patient presenting with intellectual disability, congenital malformation, genital ambiguity, and even short stature in girls, all these are indications of doing a karyotype. Next slide. But karyotype has some problems. It takes time to do a karyotype, and karyotype has a limited resolution. So those structural problems, sometimes if they are very, very tiny, we will not see in karyotype. Next slide. So then we have to do some other tests in such cases to look for these tiny problems in chromosomes. So these tests are overall called as molecular cytogenetic tests. Next slide. So an example of a molecular cytogenetic test is FISH. So here we will be able to find out very small deletions or duplications in chromosomes. Next slide. And such tests are useful for these kind of patients. So now we have patients who are all three of them presented with intellectual disability. So in these cases, the first girl, she also had a cardiac defect. This girl also had a cardiac defect, and this boy was very obese. So actually all three of them are suffering from a microdeletion syndrome. So these are the various names. This is Williams syndrome, Prader-Willi, and Dijot syndrome. So here basically we have to use either FISH or some other test to diagnose these conditions. Next slide. Next slide. So now FISH is again very labor intensive and difficult to do, and it's very difficult to find trained people to do this test, and also it's expensive. So now we have shifted to even a better technology, which is called as chromosomal microarray. So another disadvantage of FISH is that I need to know the diagnosis before doing FISH, because FISH can be done only for one disease at a time, or maximum for 5 diseases. I cannot do FISH unless I know the diagnosis, and often we don't know the diagnosis in many cases. So there we use chromosomal microarray. So chromosomal microarray will do what? It will see that chromosome, what we were seeing under microscope, in much higher magnification, and it will like these all green lines what you are seeing, these are also basically spots on the chromosome, and all of them are represented with these dots on a slide. And by looking at some fluorescent signal from these dots, we can tell which part of the chromosome is missing or extra. So even tiniest of abnormalities we can see. Next slide. So this technique has a very high resolution. It will see very small defects in the chromosomes. Next slide. So it is like if I compare a karyotype with a microarray. So you can see this is a Google map of my city, Hyderabad. So this karyotype is a very zoomed out map. I can just see, okay, there is Hyderabad, and you can just, that's all about you can see, and Sikandrabad, which is the twin city to Hyderabad. So you can't see any details. Next slide. So this is basically studying the chromosome in a very low resolution. Next slide. Whereas when I do a microarray, I zoom in. I do a zoom in into my map, and I'm able to see many more features of the city, and I am also able to see the whole city also. So this is chromosomal microarray. It's a zoomed in view of the chromosomes, or a very high resolution view. Next slide. So when do we use it? So one I showed you, whenever any child with intellectual disability is there, then we don't know the diagnosis sometimes. So previously we used to do karyotype. Now we would preferably order a chromosomal microarray. Same thing in the obstetric setting. So whenever you have a pregnancy and there may be a risk that the baby has a chromosomal problem, in that case now it is recommended that instead of karyotype you do a microarray. So let's see what extra information it gives us. So here you are seeing a couple, again the square and the circle, and they are non-consanguineously married. They have a previous girl child who is healthy, and now in 18 weeks pregnancy, next slide, this lady has presented with some soft markers. So basically here you have pilectasis and you have mild ventriculomegaly, but there is no malformation, and the anthropometry, Leica, everything else is completely normal. So there are just 2 soft markers. So whenever there are 2 soft markers, we offer invasive testing Next slide. So here also amniocentesis was done, and the karyotype report in fact came out to be normal. Next slide. But then here we also offered microarray to this baby. So in fact this baby had some multiple microdeletions, duplications in fact all of them, but out of which this one was really significant. It is a very huge duplication, 33 MB. And this was, next slide, this particular duplicated region had many genes inside it, and it is already known that when this region is duplicated, it can cause multiple problems like intellectual disability, malformations. So this baby now with a normal karyotype actually has this duplication which was missed on karyotype, and this baby is likely to be abnormal. So with this report now the couple is able to take a decision that they may discontinue the pregnancy. Next slide. So there is now enough data which says that whenever there is an abnormality in ultrasound, if instead of karyotype we should do microarray, because in 6 to 10% cases there will be a microdeletion or microduplications, means a very small part of the chromosome will be abnormal, which we will not see on karyotype, which will come only in microarray. Next slide. And in fact now for various different anomalies, people have all, there is also data saying what is the likely yield of doing a microarray. Next slide. So when we should do a microarray, so in OBG clinic now this is said to be the first tier test in prenatal setting if there is an abnormal ultrasound or if there is a fetal demise or stillbirth. Whereas in other clinical setting, if there is intellectual disability, autism spectrum disorder, malformation, unexplained growth restriction, or a suspected contiguous gene deletion or duplication, then we will do a microarray. Next slide. So now we have studied the chromosome. Now what about the single gene disorders, or how do we look into the DNA? So this particular branch is called as molecular genetics. The previous chromosome study is cytogenetics. So in molecular genetics, we want to now sequence or look at the DNA to diagnose some diseases. So these are basically these diseases are called as single gene disorders or Mendelian disorders, or even monogenic disorders. They have different inheritance patterns. Next slide. Depending on where that particular gene is located. Next slide. So there are again various techniques which are there to study these problems in the DNA. I'm not going to elaborate all of that. Next slide. So we will just try to understand what we are doing here. So when we were looking at chromosomes, we were here when we were able to see some big problems in chromosomes in number or structure. Then as we increased our magnification, we were here when we were doing microarray, and we were able to look at some very tiny problems in the chromosomes. And now when we want to look at the DNA, we will increase our magnification even more, and we will look even more deeper and at a higher resolution, so that I can read the sequence of the DNA and I can see actually what is there, A, T, G, C, in what sequence they are coming. Next slide. So to do this sequencing, there are two ways. One is standard sequencing. This is again the old and still the gold standard technique to sequence DNA. But the problem with it is that again you have to know the diagnosis, you have to know the gene, and you have to know exactly where to look for the mutation. So it is often not possible to use this in clinical settings. In some situations we can use it, but not in all. Next slide. And whereas now what we use is next generation sequencing for many patients. So here what we are able to do is that we are able to sequence the whole of the DNA, at least the coding part of the DNA, and we can, even if we don't have a diagnosis in hand, but we are suspecting that patient has a genetic disease, or like in obstetric settings, when in the ultrasound there is an abnormality, microarray is normal, but we still think that baby maybe has multiple findings, and we think that this could still be a genetic condition, then we would use this technique. So this is going to sequence all of your coding DNA, and then it will tell us if there is a mutation anywhere. Next slide. So again, just to give the analogy of the map, if I do standard sequencing, I put on Google Earth, but I can focus, I zoom in, but I can see only one small thing at a time. So here this is a view of Charminar, which is a monument in my city. So, but by doing standard, I can just look at Charminar. I can't see anything around Charminar. Next slide. Whereas when I'm doing NGS, I can look at almost the whole city of Hyderabad, and I can also look at different features in the city at different points. So I'm able to look at the whole of able to look at the depth in more higher resolution or higher magnification. Next slide. So just keep pressing next 3 times. So here basically how do these kind of diseases, so when in fact in an OBG clinic, when now you should think that this could be a genetic problem. So these kind of patients will present in 3 settings. Sometimes they come pre-marital period, either with some genital problems or amenorrhea, or they could present with sometimes also nowadays with consanguinity or family history of genetic disorder, or they can present pre-conceptional period, that is before conceiving, where again they can have some fertility issues, or they come because they are having recurrent pregnancy loss, or they are fearing that they may be born with a genetic disease because somebody in the family has a genetic disease, or they are married in relation, or many times patients come after they become pregnant, either because there is some problem in the ultrasound, or because often in our country they are referred very late, so they go to the obstetrician and the obstetrician finds out that previous baby has some problem, and then they come to the geneticist saying that now what is the chance that this baby can also have the same problem. So these are the various settings where we need to think that okay, maybe is the patient having a genetic disease, what should I be doing next? Next slide. So first we'll just see in the prenatal period, so when there is an ultrasound abnormality, next slide. So whenever there is an ultrasound abnormality, especially a structural abnormality, means some malformation in the baby, even if it is a single malformation. So any malformation can have a genetic basis, and from newborn data we know that 15 to 35% cases or children who have a malformation are actually suffering from a genetic disorder. Next slide. So these kind of genetic disorders again can be of the 3 classes we talked about. So like here is an example of heart disease. So if a baby is born with a congenital heart disease, baby could be having a chromosomal disorder like Down syndrome, baby could be having a microdeletion syndrome like Dijot syndrome, or baby could be having a single gene disorder like Noonan syndrome. So any 3 category of genetic disorder could be there in that baby who is presented with a heart defect. Next slide. And the same thing is true with breast, next twice. Same thing is true with various other malformations or ultrasound findings. In all these kind of abnormalities, baby could be having a a chromosomal problem, copy number problem like microdeletion, microduplication, or a single gene disorder. So anytime, especially in pregnancy, if there is an abnormal ultrasound, we should know that there are so many types of genetic disorder which are possible, and we should not stop at doing just a karyotype for the baby. We should definitely think more beyond that and offer even more testing, because now testing is available and it would not be either do justice to the patient, and it would cause medical legal problems also in future if we are not aware and if we are not able to offer them a comprehensive testing. Next slide. So next. So why we want to pick up these genetic disorders, especially antenatally, because a baby with heart disease, the heart disease can be repaired. But if this baby has a genetic problem because of which the heart disease is there, the baby will have other problems like intellectual disability, hearing problem, and these problems cannot be treated by any intervention. So, and these can't be seen in scan. So unless we do testing, we can't pick up these. Next slide. So here it's just an example of one family. This is a consanguineous family, and they had one girl child who had developmental delay, corpus callosum agenesis, and so many other problems. The child had died. Next slide. And workup of this child was not done. Next slide. So in pregnancy, this lady again presented with baby had again corpus callosum agenesis. Next slide, which is confirmed on doing a microarray also. So on MRI also. So usually if you see only isolated corpus callosum agenesis on an ultrasound, actually a large majority of these babies will be normal, around 70%. But 30% of these fetuses will have a genetic disease, and then they are going to have intellectual disability and other problems postnatally. Here we already had this family where the first baby had those problems. So here we were already able to counsel her that most likely this baby will also be like the first baby. So they terminated this pregnancy. Next slide. And this fetus did not have any other malformation, but on brain histology there was abnormal cortical layering, X slide, which was seen, and then here because they were consanguineous and 2 babies had the same disease, so we suspected this is an autosomal recessive disorder, which is a single kind of inheritance pattern of a single gene disorder. So we did this exome sequencing, which is nothing but next generation sequencing, and we were able to find that this baby had the mutation, a particular mutation in this gene. Next slide, which is called as disease called as Vicky syndrome. Next slide. Next slide. So here basically in this family, because now we were able to give a diagnosis, we are knowing that this family, the baby has this mutation, and we know the diagnosis of this condition, which is autosomal recessive. So now there is a 25% chance that their next pregnancy also will be similarly affected. And corpus callosum we know we cannot see in scan till 18 weeks. So if we wait for ultrasound to do the prenatal, it will be late for the lady. But now because we have a mutation, we can offer her CBS at 11 to 12 weeks of pregnancy, and we can offer her early definitive prenatal testing. Next slide. So luckily this family had a normal baby the next time after prenatal testing. Next slide. So in that particular case, we made a diagnosis after the termination. Here, this pregnancy, we made a diagnosis before, when the ultrasound abnormality was there, and we were able to counsel the family, and so that they were able to take a decision whether they want to terminate or continue pregnancy. So this is in fact a situation where a family continued the pregnancy despite knowing that baby has a genetic condition. So here, this again was a concernless couple. They had terminated one baby with suspected skeletal dysplasia. Now again at 24 weeks, baby had short bones. Next slide. So we can see these are the measurements of the upper limb bones, and the ulna and the radius, the forearm bones are very short. Next slide. And the same in the lower limbs also, the bones are short, more the tibia and the fibula. Next slide. So besides this, the baby's thoracic circumference was normal. Next slide. So with this, what we were able to say that the baby has moderately short bones, which are mainly the middle segment bones. So we call it as mesomelic skeletal dysplasia. But because the thoracic circumference is normal, this is a non-lethal type of skeletal dysplasia. Next slide. And then this baby also had other problems, like some facial dysmorphology was there, like a frontal bossing and some flat mid-face hypertelorism. Next slide. And also had, next slide, vertebral segmentation defects. So with all this, putting this together, we were able to make a genetic diagnosis. So to make a clinical genetic diagnosis, we have to put all the things together, and then we sometimes get a spot diagnosis also. So this is one such situation. So this all these things are seen only in one condition. This is Robinow syndrome. Next slide. So we did amniocentesis, we did exome sequencing on the DNA, and we were able to confirm the mutation in this gene, and we were able to confirm that baby has Robinow syndrome. How did this help this family? So already on scan we know it is a non-lethal skeletal dysplasia. But the other things that sometimes some skeletal dysplasias can have intellectual disability or other problems. Now because we know the diagnosis, so Robinow syndrome is a good prognosis condition actually. Here the short stature also will be in moderate range finally when they are adults. So it's not like very short baby. It's going, as an adult they were going to be around 145 centimeters, which is not that bad. And then they are not usually, most of the structural defects we have ruled out, and these children are going to be intellectually normal. So basically the only thing the parents are now faced with is that the baby will be somewhat short, and this couple were very keen to continue this pregnancy. Next slide. So they did that. This baby was born. Next slide. And this baby had these short limbs, what we can see here, and then had some other findings, facial dysmorphology. Next slide. And some digital abnormalities. Next slide. And also the vertebral segmentation defects, some minor rib defects, and the mesomelia. So which confirmed what we had confirmed, seen prenatally, and also confirmed by molecular testing. Next slide. So now we have enough data which says that when there is a problem in scan, a structural abnormality, 20 to 30% of these cases will have a single gene disorder. So just doing a microarray is not enough. We should also be looking for these single gene disorder, and this helps us because we are able to prognosticate the family. If the case turns out to be like the first case where it is poor prognosis, then they can decide to terminate. If the situation turns out like the second case where it's not such a bad prognosis condition, they can take decision to continue. So it gives families more option and gives them clarity about the outcome of the baby. Next slide. Next slide. So there are some guidelines now which have been published which tell us how to order this kind of test in the prenatal setting. more than 100 fetal exomes, and we have shown what is the yield in our country. Next slide. So what we have seen is that for us, around 44% of such babies who are having structural abnormalities, they all are, these 44% of them are affected with single gene disorders, which can be picked up by doing exome sequencing. So that's why, especially for our settings, because we have lot of inbreeding and consanguinity in our population, so we have lot of autosomal recessive disorders. So for Western population, it's much less. For us, it's much more. So we should be thinking and prioritizing exome sequencing in prenatal testing, sometimes even before microarray, depending on the situation. So for us, the yield is much higher. Next slide. So then, just to briefly go through recurrent pregnancy losses or POH. So again, we saw the case scenario. Next slide, where that lady had a translocation, so she was having recurrent miscarriages. So chromosomal abnormalities, next slide, are one of the cause of RPL, and this should always be tested. So couple karyotype should be done. Next slide. And then besides this, rarely you can also order inherited thrombophilia workup. For some couples, when you have ruled out everything else, and there is especially a late trimester pregnancy loss or a history of thromboembolism in family. Next slide. And besides this, POC cytogenetic, next slide. POC cytogenetic testing can be done in some specific situations, but this should not be the first test you should be ordering. First test is the couple karyotype, because POC, even if it is showing Down syndrome does not usually happen again and again and cause RPL. It is the couple chromosomal abnormalities which will cause RPL. Down syndrome may cause one miscarriage. So doing a couple karyotype is the first priority. Next slide. So here again, this situation, why I have shown this, so we are all aware that in RPL we should do couple karyotype, but in RPL also, especially if it is late RPL, again we should now start thinking about single gene disorders also, and again not stop at karyotype. So again, it depends on the situation. So here this family, again consanguineous multiple miscarriages, and again this 14 weeks IUD baby. Next slide. Baby had hydrops on ultrasound. Next slide. And this was brought for autopsy. Next slide. And some dysmorphism is there, some hydrops is there. Next slide. And but the interesting thing was the cardiac finding in the baby. So what we can see here is, this is the heart of the baby, and this whole thing is the left ventricle, and only this tiny thing is the right ventricle. So basically, this is a hypoplastic right heart in the baby. Next slide. Here the microarray of the fetus was normal. Next. And we did whole exome sequencing. Next, and we were able to find that the baby was homozygous for a mutation in the PLD1 gene, which causes a right-sided cardiac defect. So which is consistent with the fetal findings. Next slide. So this kind of confirmed the diagnosis in this family. Next slide. And here is just a segregation what we have done in the parents. Next. So here again we are able to say this is autosomal recessive and the recurrence risk is 25%. But here in this family there are two first trimester miscarriages also. So that is not likely to be because of this. For that we have to do other workup. But basically for this family we can now provide them either prenatal, or if because they are having early losses, they can go for IVF and PGTM based on this mutation. Next slide. So in RPL BOH, chromosomal abnormalities and single gene disorders also have to be considered, especially if there is a late RPL. So in late RPL, that is after 12 weeks at least, we should send the fetus for an autopsy, whereby the fetus can be examined and we can see whether there are any dysmorphism or other findings. And we should also do DNA banking for this fetus, and then we can do the further genetic workup. Next slide. Next slide. Next slide. So finally coming to infertility also, again one situation we saw is that girl who presented with amenorrhea. So mostly Turner syndrome is one diagnosis we have to keep in mind whenever there is a premature ovarian failure. Usually the mosaic ones are the ones who may come to the infertility clinic, because the mosaic Turner will have some cycles and then they go into POF. So they may present with secondary amenorrhea and infertility. So chromosomal abnormalities is again one of the things, but here this is one case where there is something else. So this girl with secondary amenorrhea again with hypergonadotropic hypogonadism. Next slide. So she, when we took the family history, we found that she had two brothers with intellectual disability. These are the photos. photos of her brothers, and they have some characteristic facial dysmorphism. So actually here what was there is that these brothers were affected with fragile leg syndrome. So fragile leg syndrome is a triplet repeat expansion disorder, and the test we used is TP-PCR. So actually the brothers had a large number of repeats in this gene, FMR1 gene, and the patient had what we call as a pre-mutation in this gene, and pre-mutation or small expansion in FMR1 gene presents with POF. Next slide. So around 2 to 5% of sporadic patients with POF, that is no family history, only POF, they will have this FMR1 expansion. And if there is a family history, this figure will be 15%. And it is important to pick them up because this lady tomorrow, when she reproduces by ART or some oocyte reservation is done and then that is used for ART, the child may, if it's a boy child, will be intellectually disabled. So you can prevent it if you are able to pick up the FMR3 mutation in this lady. Next slide. So there are of course various other chromosomal abnormalities which can be cause of POF and present as female infertility, and various single gene abnormalities. Next slide. Next slide. So for all women we should do a karyotype and a fragile X pre-mutation testing, and this could also be done in women with poor ovarian reserve or women who are poor responders to ART. And next slide. And also if you're not able to find any cause, then you can also use NGS-based testing for some cases. Next slide. So sometimes even tubal factors can be because of genetic reasons when you ruled out infections and other adhesions and other causes. So cystic fibrosis or sometimes even ciliary dyskinesias can present like this. Next slide. So here like we have these siblings born of consanguineous parents, both of them are infertile and they also have some sinusitis, bronchiectasis. This brother has oligozoospermia with poor sperm motility. So this lady was actually found to have a primary ciliary dyskinesia. Next. And brother was also similarly affected. Again, why is it important to make this diagnosis? Because tomorrow if this sperm is used for ICSI, if this sperm is used for IVF, this sperm, it is better to go directly for ICSI because there is a motility issue in the sperm and it may not respond to the conventional ART. So to make the diagnosis helps also in choosing the appropriate course of management for that patient. Next slide. Next. Next. Again in males we have to rule out Klinefelter syndrome by doing a karyotype. Next. And in case of absence vas difference we should keep cystic fibrosis in mind. Next. And also AZF deletion is very important. So males who are eugonadal but azoospermic or oligospermic, for all of them we should be doing AZF deletions because again they are a very common cause of these poor sperm counts. Next slide. Next. So why it's important again because this male person, often many of these AZF deletions, especially the AZF-C deletion, will have sperms in their testes and these can be aspirated and used for ART. And so in such a situation, their male child is also going to be infertile. So that's why it's important to diagnose this. Next slide. So now we also have data which is there of various other genetic defects which have been found in women who are not responding to ART, who are having recurrent implantation failure. Next, or who basically have situations like poor ovarian reserve and are having empty follicles on aspiration or some abnormal kind of oocyte. So these all are presenting with recurrent IVF failure. Many of such women are also having genetic abnormalities, and if we are able to diagnose them beforehand, we can directly offer them donor ovum rather than going for all these repeated IVFs. So next slide. So finally, again in IVF settings and otherwise also, now when these couples after so much of effort and so much of money they are going for IVF, one more thing which can be offered to such couples, especially if they are consanguineous, is to carrier test for various single gene disorders, autosomal recessive and X-linked recessive disorder. Because after so much effort tomorrow, if they are carriers of some disease and their baby is affected with that disease, all that effort goes in vain. So what is now available again because of technological advancement is that we can offer NGS, that is exome sequencing, to the husband and wife before they plan a pregnancy or before they go for IVF, and we can see whether they are carrying any single gene disorders. Next slide. So here in this family, actually they already had one affected child who had died. So this was a consanguineous couple, and this child was a 9-year girl. I mean, she died at 9 years, and she had a genetic condition called as tyrosinemia. Next slide. But there was no genetic workup done for this child. So tyrosinemia is an autosomal recessive disorder. The recurrence risk for them is 25%. Next slide. So, but we don't have the DNA of the child. So what we can do is that we can do carrier testing of the parents. Next slide. So how to do carrier testing of the parents? So the test which was used was again exome sequencing, because they are consanguineous couple. So exome sequencing will help us to see carriers of tyrosinemia as well as carriers of at least 2000 autosomal recessive disorder at one go. Next slide. So in fact this couple was found to be carriers of 3 diseases. So they had this mutation, carriers of tyrosinemia related mutation. Next slide. Then they were also carriers of 2 very rare conditions, one which causes a renal problem, next slide, and one which causes a intellectual problem. Next slide. So now this is a couple who is carrying 3 autosomal recessive disease. Their baby could have 1 disease, 2nd disease, 3rd disease, or both 2 diseases, any combinations, or all 3 diseases. So the chance that they may have a normal baby is only 42%. So from 75%, if it was tyrosinemia only, it has dropped to 42%. So for such a couple now, the options besides prenatal testing is to go for PGT-M, to select the embryo which doesn't have any 3 diseases, or to go for a donor for one partner. And we had discussed all these things, but finally they opted for adoption, because they were feeling that after dealing with the child for so many years, the husband especially did not want to put his wife through all the cycles of IVF and so many things. So he said very clearly, I will go for adoption. I don't want to take all these risks, and I don't want to go for any of these things. So doing this kind of carrier testing can give your patients more choices to ensure that they are able to have a healthy baby. So now there are guidelines also published, but Indian guidelines we don't yet have to how to do carrier testing and for what conditions to do carrier testing. Next slide. Next. So another next. So sometimes genetic testing also helps us in finding some new conditions or discovering new disease-causing genes. So in fact, these were once siblings who both of them were intellectually disabled and had some other features which were not fitting into any known genetic disease. Next slide. So on research basis, we had done exome sequencing for both the siblings. Next. On both the siblings, and we were able to find that both of them had mutation in one particular gene, next, which is called as HERF1 gene. Next. So this, in fact, when we found this was the first time that mutations in this gene were known to cause intellectual disability. Next slide. And we did some functional studies to prove that this is impacting the RNA and the protein of those children. Next slide. Next. So by the time we were able to publish this, so when we had found this, we were the first in the world to find it. But for us in India, everything moves slowly. So doing all this functional work, everything took us at least 6 months. So by the time we were able to publish it, 2 more people reported the same gene to be mutated in their patients. So they were from very different ethnicity, we can see. So, but then next, if we see the next features of these patients, the photographs, we can see the similarity in their face. They all have very long face and have some prominent forehead and other dysmorphism. So doing these kind of advanced genetic testing also helps us in situations where we can describe some new conditions, or we can help some families who till now have no diagnosis and they have been roaming for years to different doctors and trying to get a diagnosis for them. Next slide. So finally, to the last part, which is precision medicine. So how does this help in treating the patient? So at the end, whatever I talked about is making a diagnosis, telling the prognosis, doing counseling. does it help in treatment of the patient at all? So to some extent we saw that yes, we can change some management, tailor some management depending on the genetic mutation. But now we are in the times where the actual mutation can help in devising the drug for the patient and the best possible drug for that patient. Next slide. So what conventional medicine is that every patient is given the same drug. Some will respond, some will have no response, some will even have adverse effects. Whereas now when we combine the genome of the patient and other factors, we can design a drug for that particular patient only. And this will cause the best effect for every patient instead of resulting in adverse effects or no effects. Next slide. So I don't think it's possible to read this. So basically now what for various genetic diseases also, depending on the mutation, we have some drugs available. And for at least 3 conditions, beta thalassemia, spinal muscular atrophy, and Leber's congenital amaurosis, these all 3 are genetic conditions. For all these 3, gene therapy has been approved and is now available in the clinic, and it can be given to patients. In fact for SMA, I'm sure all of you must have read in the newspaper, it's the most expensive drug. It causes 16 crores, and patients are now, many of the patients have got this through crowdfunding. So these kind of drugs are now available, and there are so many trials going on for gene therapy for many more genetic diseases, and soon we anticipate that for many conditions this would become mainstream. Next slide. And this in fact is the prime example of that. This is not gene therapy, but this girl is the example of how for one patient, one mutation, a drug was designed that worked only for her and nobody else. And this was over a period of the diagnosis being made in 2016, and by 2018 they were able to make a drug for this girl specifically targeting her mutation. And after all this involved animal studies and other trials and all, and this is the girl who received this particular drug, and this is the future where we can actually hopefully for every patient design a mutation specific drug and finally offer treatment for all these genetic conditions. So I think this is my institute, the Nizam's Institute of Medical Sciences.
And thank you very much for enlightening the role of genetics in medicine, and we really truly appreciate your efforts. Just to highlight, we have some short presentation of some 2 cases which they'll be just presenting to you, and probably tell you your opinion.
Thank you. Sure.
You can sit down.
Good evening, Raju sir. Yes, sir. Good evening, Raju sir, Gopinath sir, Agrawal madam, and all. I'm presenting our case which we saw recently in our. Okay. I'm presenting this case which we saw recently in our clinic. Next slide. I'm a fetal medicine consultant in INAC department. And next slide, please. This is a case of Mrs. S.V.J. who was 31-year-old second gravida with 1 abortion and was married for 1.5 years. This was a non-consanguineous marriage. This pregnancy she conceived with ovulation induction, and she had come for at around 19 weeks and 6 days for her routine target scan, that is animal scan. Her other history, like her blood group was O positive, her cycles were regular. Next. Regarding her obstetric history, it was first was her missed abortion around 1 year ago, and she had undergone dilatation and curettage for the same. And this was her second pregnancy, which she conceived after ovulation induction. She was a known case of hypothyroidism since almost 10 years and was taking thyroid tablet. Her father was diabetic and was on treatment. All her previous scans, her first trimester screening for trisomies 21, 18 and 19 was screen negative. However, she was screen positive for preeclampsia, and so she was started from on tablet ecosprin 150 milligram. Next slide. At this scan, the pregnancy, the growth of the baby, activity, lifestyle, everything was normal. It was according to the gestational age. However, on the fetal face examination, which was seen in all the views like coronal view, axial, sagittal views, also in 2D and 3-dimensional evaluation, orbits and nostrils, lips, they were seen, they appeared normal. However, the face profile, it appeared to be flat, or we can call it as a flat face profile, and the nasal bridge was also depressed. The condition was called as a binder's phenotype. Next slide, please. These are the ultrasound images suggestive of binder's faces. The nose appears to be flattened in this image. Next slide. The 3D rendering for the same. So binder's phenotype of binder syndrome is a condition which is characterized by hypoplasia of anterior part of the maxilla and nasal complex. There is a hypoplasia of midface, especially in the anteroposterior direction. The profile view shows a concave appearance. The nose was flat. The length of the bone, however, appears normal. Lips, they look thick. Next slide. So the differential diagnosis for the condition is, one of it is chondrodysplasia punctata, where which may show other findings also on the ultrasound like stippled epiphysis, or there may be rhizomelic shortening of the limb, or spine abnormalities, or cataract, or other cardiac diseases, or some anomalies of the skin. The babies may also have a hearing loss in this condition. However, in the present case, next slide please, the spine and the bones, they appeared normal for this baby. Even the heart was also anatomically or structurally normal. Other conditions which may present with the flat facial profile or the binder's phenotype may be like Wolff-Hirschhorn syndrome or Robinow syndrome. All these conditions also will present in a similar way. These are the other pictures from internet which were showing the similar flat or the maxillofacial hyponesia like Stickler syndrome, camphomelic dysplasia, henotropic dysplasia, Pallister-Killen syndrome. After explaining the scan findings to the patient, we asked her to go ahead for the genetic counseling.
First thing here, what we need to realize about binder phenotype is that it is a phenotype. So it is not a disease per se. So often, in many cases, if otherwise the scan is normal, it may be a familial variant. So it is just the structure of the face or the nose which is specific to that family. So it is very important, one thing, to look at the parents immediately if you see a binder faces. So one of the parent may be having a flat nose or a
but
short
they looked,
nose,
they had a prominent nose. I
yeah.
saw that.
So again, here also it is important sometimes to look at their childhood photographs or to ask them more in detail. Because sometimes what will happen, some of them may have got operated. In fact, one of the patients I had, she gave this history that when I was small, my face was like this, and then I got surgery done, cosmetic surgery done. So always ask, because when you know, then only you will ask those things. So we need to inquire more in depth. So first thing we need to keep in mind is that it may be a normal variant to in that particular family, and we look at that, their faces and other relatives also. Second thing we also need to rule out is Down syndrome. So many often this Down syndrome may also present, we know that it presents with absent nasal bone or hypoplastic nasal bone, but sometimes it may be more severe kind of a nasomaxillary hypoplasia and mimic binder phenotype. So definitely testing for that, counseling and testing for that that is to be done. And as you showed in your presentation itself, two more chromosomal conditions, Pallister-Killian and also Wolff-Hirschhorn syndrome, and so many other also actually some, like I mentioned, microdeletion syndromes, like some other submicroscopic chromosomal abnormalities can also present similarly. So that's why we should not stop at doing a karyotype for Downs. We should preferably do a microarray. So we offer this couple invasive testing and we do chromosomal microarray. So that is the first thing. Second is that there are so many other conditions like you mentioned, so of which the most important one is chondrodysplasia punctata. So again, that chondrodysplasia punctata and some of the other conditions, what you mentioned, Stickler, Robinow, these are all single gene disorders. So these will not come in microarray. So, but most of the times they will show some scan findings in most cases. So we should expect in chondrodysplasia punctata some epiphyseal stiffening in the joints, in the spine, sometimes in the larynx, trachea. They may be there. So we need to carefully look for those in the scan. Let's assume it's normal, nothing is there. Then there are two options. If your patient can afford, then at the time of microarray you offer her exome sequencing also, so that you can rule out the rest of the single gene disorders. Because sometimes what can happen that now at 19 weeks you may be seeing that binder phases, you may not be seeing stippling. When you call her again after the scan, then you will start noticing the bones are becoming shorter, they are crossing centiles, or some stippling is coming up, and then it will be too late. It will be too advanced a gestation to take any decision. So if the patient can afford, in the beginning itself, you can offer them exome sequencing. Otherwise, keep her on a skeletal biometry, serial biometry to monitor the skeleton. And again, if everything continues to be normal, your microarray came normal, exome came normal, or if you didn't do exome but the follow-up scans, everything is normal, then we can actually reassure them that it's going to be a normal outcome only. One more thing which is important in the beginning itself when we are taking history, to inquire for any teratogenic influence, especially the vitamin K antagonists. So warfarin and other vitamin K antagonists she doesn't have. Okay. Because they can also mimic chondrodysplasia punctata and have similar presentation. Or maternal SLE also is really reported to have the same. So those history we should take, that may give us an answer as to why the baby is looking like this. But if nothing is there, then it's like it's going to be just a cosmetic issue, and very often afterwards some babies may require, you need to be aware that some airway means depending on the severity of the hypoplasia, some children may have some breathing problems and some airway issues. So the neonatologist should be made aware that this baby is getting delivered, so that that baby can be given.
And hearing issue, what we should tell about that?
Hearing issue, we expect only if there is a significant airway, like prenatally we cannot counsel for hearing issue.
Not.
No, not at all. But yes, after birth, depending on the airway involvement, if they are, there is a restriction, they may be prone to middle ear fluid and all, recurrent infection, that may cause hearing issues, but those are rectifiable mostly. It's not going to be a sensory neural type of hearing loss which you cannot rectify. So that is just secondary to the facial this thing.
Can I use this mic?
Again, thank you all for the opportunity for giving me the opportunity to present this case today. So this couple has come to us a couple of days back and it's quite puzzling. So this is a 28-year-old, a young couple, 28 to 29-year-old, who married for 4 years, non-consanguineous marriage, and they give us a history of recurrent pregnancy loss, which I will elaborate later on. And both seem to have a normal physical appearance with no known comorbidities. They have no significant family histories, and all their siblings are doing well. So first abortion happened in 2019. She had spontaneous conception, FSH was documented dating scan, and then she had a bleeding scan was done again. She had a missed abortion, which was medically managed. So then again, 5 months later, when she conceived again, obviously any kind of ultrasound start her on progesterone support.
documented effects at 6 weeks. Again, she had missed abortion at 8 weeks, which is also medically managed. So, having 2 abortions as history, given all the whole panel of investigation was done, all turned out to be normal. Next slide. Except the homocysteine, which is moderately high, and there's vitamin D deficiency. So to correct the homocysteine, they will start on multivitamin supplements, vitamin D, folic acid, low molecular weight heparin was also started, along with aspirin, luteal phase support with oral progesterone, and she was asked to plan her 3rd pregnancy, which also resulted in another missed abortion at 9 weeks, which was also medically managed. So then, again, after the 4th abortion, vitamin D was rechecked, that was found to be corrected, and then they went on to investigate the beta-2 mitochondrials and dsDNA, and karyotyping was done for both husband and wife. The wife found to have 46 XX with increase in length in the one of the regions of the chromosome 9, which is also told to her that it was a normal variant and may not be the cause of a miscarriage. So again, another panel of investigation using for APLA, varicella zoster, cardiolipin, GTT was all done, all found to be within normal limits. Vitamin D was, though less, it was okay. B12 was normal, folic acid was normal, ultrasound down only PCO and small adenomyoma, which again in the later subsequent scans that was not there. And her anti-gliadin IgA was low positive, but then again all endomysium antibody, her methylene tetrahydrofolate reductase mutation was not detected, transglutaminase antibody was all negative. So the investigation, so much histogram was done to rule out the uterine causes, and again that was normal, adequate distinction, regular endometrium, normal myometrial junction, and free food in the POD. So she was left, and male causes was investigated. Several analyses were done in different laboratories, out of which one found to have a head defect of 90%, so again BFI was done, which is normal, by CSA 16%. Semen culture and CRP were both done, that was also normal for him. So while under this investigation, she conceived for the 4th time, and she was on a long list of medications again, with oral metformin for the PCO, oral dydrogesterone, aspirin, progesterone, low molecular weight heparin 0.4, and HCG injection. She still had a miscarriage at 9 weeks. DNA was done. Those product of conception was done for karyotyping. That was also normal. So whole genome exome sequencing was done. That he had no problem. She was found to have positive for a carrier for autosomal recessive condition called infantile hypotonia with psychomotor retardation characteristic phases 2. And along with another panel of investigation was done, including CD319 and CD56, and all was within normal limits. Her D-dimer and fibrinogen was done. Fibrinogen was around 453, which is high. And when she conceived again, she sought Ayurvedic treatment this time, and again ended up having a miscarriage. And DNA was done, products was sent again, and reported to be normal. Another round of APLA, PAN, lupus, CBC, adiocantin with the ANA, ultrasound, BT-CT were all done. It was also normal. So she had a break for 8 months. She conceived again in December 2022, and she was given including oral prednisolone, and low molecular weight heparin was increased to 0.6 ml. At 8 weeks, she had a blighted ovum, and DNA was done in Jan 2023. To summarize, this is a young couple having 6 recurrent first trimester miscarriage. She was corrected for the hyperhomocystinemia, corrected vitamin D deficiency. Only positive here is that anti-gliadin IgA positive, and positive for an autosomal recessive condition with a raised fibrinogen level, which is again manageable with low molecular weight heparin and oral aspirin. And all the product of conception karyotyping was normal. So ma'am, how do we further proceed and manage this patient?
This is a very tricky situation, and we may not always have an answer also, but still in this case is one or two things I would like to see more. So one is that this POC chromosomal microarray was not done at any point of time.
No, ma'am. Only karyotyping was done.
So one is that in such a case where we have really done the whole workup and there is no cause, so one test which should be done is a POC chromosomal microarray, a high resolution microarray. Why? Because sometimes some of the couples may have a translocation which is very tiny, which is below the resolution of a karyotype, and that will not come up in the couple karyotype. So that we call it as a cryptic rearrangement or a cryptic translocation. So for looking for that kind of translocation, maybe again and again giving rise to these abnormal gametes, and that may be causing these miscarriages. So if we do a POC karyotype, and that also a high resolution karyotype, which is a 750K, which is available in India as of now. So that may show up these smaller chromosomal abnormalities, and which could then, if suppose it's there, then we can do some other testing for the parents to look for the translocation, like spectral karyotyping and other. So that is one thing I would advise this couple if some sample is there still. Besides that, suppose if that also comes to be negative, which is so the yield of doing this kind of microarray in such cases is just 2%. So 98% I'm expecting that also is going to come normal. So now the thing is that many such couples are there for which despite doing everything there is no cause found. So you've already done a exome sequencing for the couple.
Came with the reports.
Yeah, right. Okay. So the wife is a carrier of one particular autosomal recessive condition, but we are not worried about that because husband is not a carrier. So only when both the partners are going to be carrier of the same autosomal recessive condition and they have a pathogenic or a likely pathogenic variant, then only there is a risk to the baby. And the risk is also of a pediatric disease, which is not a miscarriage or cause of miscarriage. So such unexplained cases now people, again there is no clinical answer to such situation, assuming the microarray also comes normal. But there is now research going on and there have been at least 2 or 3 publications which are showing that there could sometimes be some mutations mainly in the mom or sometimes in the couple, which is causing a very early embryonic demise. So again, that may not be there in available, or those things are not analyzed as part of a routine exome what the labs are doing, because we are looking for only conditions for which well-defined OMM phenotypes are there. So when the lab analyzes the exome report, it will look for only conditions which we know that this is a disease which happens because of this mutation. But this is an emerging area of research whereby in some studies there have been found to be certain mutations in the couple or sometimes only in the mom, which is predisposing again and again the baby to have an early embryonic demise. So it's like same like I had shown that late RPL. So late RPL, we know that many of them, once we have ruled out chromosomal abnormality, they may be having single gene diseases. But now people are focusing on the early RPL, where no cause is found despite accurate, so much comprehensive work. So some of those cases may also actually be having some single gene disorders, which we don't know as of now, for which we still need to do further studies to be able to define those cases. So I think she may probably be a candidate for such a study basically. So here, because already the exome is done, if the data is reanalyzed to look for like those studies, we can kind of review and we can see what things people are reporting could be causing early embryonic losses, and we can reanalyze the exome data of this couple and see if they are harboring any such variants. But as I said, this is still a research field. It's, clinically, we may not be able to offer them a solution as of now.
Thank you.
Thank you.
Thank you. I'm an endocrine surgeon. First, let me congratulate since Dr. Raju, Dr. Gopinath, and Vikram for starting Madam also for this genetic clinic. Now, coming to this case, there are 2 points repeat.
Clinic
for all specialty. This is a new branch of medicine which aims in helping the individual pattern and how to address and how to...
We are going to have to support the individuals and the family. Genetic pattern and interpretation of their patients with their reports. There are 4 components. One is risk assessment, then knowledge what is the pattern, and we have to explain the awareness to be created within the family individuals. Then we have to give the choice, informed choice. Some people will accept what is available, they will accept the family. What is the disease pattern? Some people may not like it. Therefore, we have to give choices for them, what is possible. Then the supportive counseling. These are the 4 factors which is considered. And madam, we are happy to have the senior most professor Dr. Shana Agarwal, who has come here to enlighten us about genetic counseling. And thank you for being here. Thank you. Enjoy your day. Thank you, sir.
Thank you, sir. Presentation on medical genetics in the clinic. Over to you, ma'am. Because it has really become very all-encompassing, and the technology has evolved so much now that it is actually coming very rapidly.
Alkaline phosphatase, okay, and the parathyroid gene.
Thank you, sir. Check. I now call upon Mr. Jeshnu from Lifestyle Diagnostics to render the vote of thanks.
So it was a very warm good evening actually, because a lot of quite doubtful cases put forward by the consultants here. The entire idea of such a genetic clinic is exactly this. How do we find out solutions for these sort of problems faced by the consultants actually? So that is where we are trying to bridge a gap actually by introducing a genetic clinic from Lifestyle's team in working in tandem with the SIMS team to ensure that every patient coming into this hospital is going out with a perfect solution actually, what to be done next actually. So we do take this opportunity to take upon this big challenge in supporting SIMS continuously from here, as Dr. Raju was mentioning that looking at the possibility, we are initiating it once in a week now, then slowly but steadily looking at the requirement, maybe on a regular basis, looking at the patient flow. Lifestyle is definitely ready to support SIMS on the need of such a situation also, because we do have the manpower strength also to handle such scenarios. So that assurance also we are providing it from Lifestyle end actually. And would like to thank our chief guest actually, Dr. Shagun Agarwal. Yes, we are always happy to have such stalwarts coming to such clinics and inaugurating and sharing their expertise. Yes, stalwarts like Dr. Ashwin Dalal, Dr. Shagun Agarwal, who are always pioneering into their segment. So we do really thank Dr. Shagun Agarwal for taking the pain to come out from Hyderabad for a single day to inaugurating this clinic and presenting and giving us a lot more information on what is this field of genetics actually. So thank you, madam, for coming down here for this function. Definitely Dr. Raju Shivaswamy, who is the Vice President of SIMS. Yes, we do thank you for your esteemed presence here. Then Dr. P.M. Govinathan sir actually of obstetric and gynecology department. I was just interacting with him, a lot of known doctors are his disciples actually. Definitely thanks Dr. Govinath also. Yes, we have been working in tandem with Dr. Vikram also. So thank you Dr. Vikram and all the other consultants of this and the admin team of SIMS Hospital and all the media persons plus all the dignitaries who have come and attended this function. Thank you all.
Sorry sir.
வணக்கம். இன்று சிம்ஸ் மருத்துவமனையில் ஜெனடிக் கிளினிக், அதாவது மரபணுவு சார்ந்த ஒரு கிளினிக்கை இன்று இனாகுரேட் பண்ணியிருக்கோம். இது வந்து டாக்டர் ஷானு அகர்வால் ஹைதராபாத் நியூமேன் சென்டர்லேருந்து வந்திருக்காங்க. இது மாதிரி மரபணு கிளினிக் வந்து எல்லா இடத்துலையும் கிடையாது. இந்தியாவில் வந்து 1-2 இடத்துல இருக்குது. இது வந்து மெயினாக வந்து ரீப்ரொடக்டிவ் மெடிசின், அதாவது குழந்தை பிறக்கும் போது அபார்ஷன் வர்றவங்களுக்கு, அப்புறம் எண்டோக்ரைனல் ப்ராப்ளம் உள்ளவங்களுக்கு, நியூரோ ப்ராப்ளம் உள்ளவங்களுக்கு, கேன்சரில் உள்ள ப்ராப்ளம், பீடியாட்ரிக், இந்த மாதிரி டெவலப்மெண்டல் ப்ராப்ளம்லாம் இருக்குது. இதுக்கு வந்து காரணமே தெரியாது. ஒரு குழந்தை வளர்ச்சிக்கு வந்து ஒரு என்ன காரணம் தெரியல, சாப்பிடலன்னு நினச்சிக்கிட்டு இருப்பாங்க. ஆனால் மூளையிலே வளர்ச்சி கம்மியாக இருக்கலாம், அதனால் டிலேடு மைல்ஸ்டோன் நடக்கிறது லேட் ஆகும், பேச லேட் ஆகும், அவங்களோட அறிவு வளர்ச்சி கூட ஐக்யூ வந்து கம்மியாக இருக்கும். இதுக்கெல்லாமே ஜெனட்டிக் வந்து ரீசன். ஒவ்வொருத்தருக்கும் ஒரு குரோமோசோம் இருக்குது. ஒவ்வொருடைய செயல்பாட்டுக்கு ஒரு குரோமோசோம் காரணம். அந்த குரோமோசோம் அதாவது இருக்க வேண்டிய இடத்துல இருந்திருந்தால் ஒழுங்காக வேலை செய்வோம். ஏதாவது ஒரு இடத்துல ஒரு பொசிஷன் மாறிடுச்சு இல்லை டெலீட் ஆகிடுச்சுன்னா அவங்களோட பிஹேவியரே மாறி இருக்கும். அதனால மொத்த ஃபேமிலியும் அஃபெக்ட் ஆகிறாங்க. இதை கண்டுபிடிச்சி இந்த மாதிரி ஜெனட்டிக் கிளினிக்கிற ஒரு நியூ கான்செப்ட். இது ஒவ்வொரு லெவலையும் ஒரு மைக்ரோ லெவலில் எப்படி வந்து இப்போ டெக்னாலஜி மாறி ஒவ்வொரு டெக்னாலஜியும் மைக்ரோ லெவலில் போகுதோ அது மாதிரி நம்மளாம் அந்த காலத்தில் ஃபோன் பேசும், பெரிய ஃபோனில் பேசுங்க, இப்போ செல்ஃபோனு, இப்போ சின்ன மினி ஃபோன் வரைக்கும் வந்துடுச்சு. அது மாதிரி நம்மளுடைய ஜெனட்டிக் ஸ்டடியும் வந்து நிறையா ஸ்டடி போயிட்டே இருக்குது. இந்த அட்வான்ஸ் ஸ்டடிக்கு வந்து டார்கெட்டட் தெரப்பி, இப்போ கேன்சர்லாம் வந்து டார்கெட்டட் தெரப்பின்னு கொண்டாட்டாங்க. எந்த ஜீன் அஃபெக்ட் ஆகுதோ அதுக்கு தகுந்த மாதிரி டார்கெட் தெரப்பி. அதை இப்போ மேடம் சொன்னாங்க. இந்த மாதிரி நம்ம கண்டுபிடிச்சதுக்கப்புறம் அதை இன்டெப்த்தாக அனலைஸ் பண்ணும்போது வந்து என்ன ட்ரீட்மெண்ட் கொடுக்க முடியும், இது ஆன்டிபாடிஸ் ரெஸ்பாண்ட் பண்ணுமா பண்ணாதா. அப்போ ஃபஸ்ட் ட்ரைமஸ்ட்டில் இந்த அபார்ஷன் பண்ணிங்கன்னா அந்த குழந்தைய வெளியில் கொண்டாந்து மொத்த குடும்பம் கஷ்டப்படுவாங்க. அது வேண்டான்னு சொல்லிட்டு அதுக்கான ஆப்ஷன் இருக்குது. ஐவிஎஃப்ல எப்படி போகலாம், இதெல்லாம் வந்து ரிசர்ச் பண்ணி கொண்டுட்டு வந்திருக்காங்க. இதை வந்து மக்களுக்கெல்லாம் கொண்டு போய் சேர்க்க வேண்டியது எங்களுடைய எய்மு. அதை வந்து டாக்டர் ஷானுகள் வந்து டீட்டெயில்டாக பேசினாங்க என்னெல்லாம் ஸ்டடி பண்ண முடியும்னு. இதை மக்கள் கொண்டு சேர்க்கணும்னு நம்புகிறோம். தேங்க்யூ.
இது முக்கியமான விஷயம் என்னன்னு கேட்டிங்கன்னா, இதில் ஐ எம் டாக்டர் Gopinath. Ready? I am Dr. Gopinath, Director of Obstetrics and Gynecology and IVF இங்கே சிம்ஸ் ஹாஸ்பிட்டலில். இதில் ரொம்ப இம்பார்ட்டன்ட் ஆஸ்பெக்ட்ஸ் என்னன்னு கேட்டிங்கன்னா, இது வந்து நாங்கள் கம்ப்ளீட்டாக ஃப்ரீயாக பண்ணுறோம். இந்த ஜெனட்டிக் கிளினிக் வந்து we are not charging, it's completely free. வரவங்களுக்கெல்லாம் பார்த்து டீட்டெயிலாக அனலைஸ் பண்ணிவிட்டு என்ன சொல்யூஷன்ஸ் கொடுக்குறோன்றது இட்ஸ் கோயிங் டு பி டன் ஹியர். ஒரு இன்ஃபர்டிலிட்டி ஆகட்டும், இல்லை திருப்பி ரிப்பீட்டடாக குழந்தைக்கு ஒரு அபார்ஷன் ஆகுது, இல்லை ஏதாவது ஒரு அப்நார்மல் பேபி ஃபஸ்ட் இருந்ததுன்னா அவங்களெல்லாம் கூப்பிட்டு வந்து ஒரு வாரத்தில் ஒரு நாள் நாங்கள் ஒரு டார்கெட் பண்ணி வச்சுருக்கோம், ஒரு ஃப்ரைடே அன்னைக்கு. ஸோ திஸ் கம்ப்ளீட்லி இட் இஸ் அ ஃப்ரீ சர்வீஸ் டு த கம்யூனிட்டி. இது வந்து நீங்கள் ஐ திங்க் எல்லாரோடையும் நீங்கள் போய் சேர்த்து எல்லாருக்கும் ஒரு பயனடையர் செய்கிறது உங்களோட முக்கியமானது. தமிழ்நாட்டில் ஒரு இடத்துல 2 இடத்துல இருக்குமா. மெட்ராஸில் ஒரு மல்டி ஸ்பெஷாலிட்டி ஹாஸ்பிட்டலில் திஸ் இஸ் த ஃபஸ்ட் டைம் த கிளினிக்கல் ஜெனட்டிக் சர்வீஸ் இருக்குது. இந்த காஸ்ட்டுன்னு சொல்லமா, இது இன்ஃப்ராஸ்ட்ரக்சர் பிரெயின் அண்ட் பென் தான். ஸோ படித்தவங்க இவங்க மாதிரி ஒரு இதிலேருந்து வச்சு அனலைஸ் பண்ணி என்னன்னு பார்க்க போகிறோம். அந்த டெஸ்டிங் எல்லாம் இருக்கிறது மேடம் சொன்ன மாதிரி ஒரு ஆர்டினரி குரோமோசோமல் டெஸ்ட் இருக்குது. அதுக்கு அடுத்தது வந்து என்ஜிஎஸ் ஸ்க்ரீனிங் இருக்குது. அப்புறம் மைக்ரோ அரே டெஸ்டிங் இருக்குது. அது போக போக அந்த காஸ்ட் எல்லாம் வந்து இட்ஸ் கம்ப்ளீட்லி டிஃப்ரெண்ட். நாங்கள் அது பண்ணுற போகிறதில்ல, நம்ம அனலைஸ் பண்ணி என்ன டெஸ்ட் பண்ணணும்னு பண்ணி அவங்கள அனுப்ப போகிறோம்.
Don't know Tamil.
English.
So,
can speak in English.
So good afternoon. I am Dr. Shagun Agarwal. Okay. I'm Dr. Shagun Agarwal. I'm additional professor at Department of Medical Genetics, Nizam's Institute, Hyderabad. So I congratulate the SRM Institute for this wonderful initiative. So at present in India, there are only around 8 to 9 centers who have this facility whereby patients can undergo genetic evaluation. They will be seen by a specialist who is super specialized in field of clinical genetics, and then following which there are different tests as sir mentioned. So beginning from small basic level genetic tests, now we have technological advancements whereby we can do very high level of genetic tests. So all these facilities as of now in India, very few centers are there, and now in Chennai this is the first multi-speciality hospital which is starting this clinic, and it is indeed a very kind of a very big advancement, and I'm sure that it would be very useful for all the patients. Many of these patients who have genetic diseases, because we don't have the specialized doctors in our country, they are never able to make a diagnosis for these patients, and they will keep on going from one doctor to another doctor, and nobody is able to understand what is their problem actually. And often in such cases, in that family, again next baby may also have the same problem. So it will run in generations, or many more children can have the same problem. So it is very important to have such genetic clinics, so that these families who don't have any answer in the current medical system, where they are not able to find a diagnosis, we are able to diagnose their conditions, and then now we are also able to make some treatments which are specific for that particular patient. So that's why this is really, which is something which is very much needed at present, not only in Chennai. In fact, it needs to spread all across India, and we need to have many more centers like this.